Okay, I hope the rest can hear me. Thank you very much, Doctor. Assalamualaikum
صوت
warahmatullahi
الدكتورة واضح يا
wabarakatuh.
اخوان.
Okay, so I am going to present our paper. Irma Ruslina Devi is a rehabilitation physician from Bandung, Indonesia.
Go ahead,
So
doctor.
yes. Can you hear? Can you see my slide? Yep, I'm sharing my screen. Can you see my slide? Yes, all right, good. So this paper was written during COVID, all right? We've never met before, so this is an evidence of tele research. Okay, I work in 3 hospitals, but mainly with the Ministry of Health at Sultan Idris Shah. So it's about 35 minutes from Kuala Lumpur. And this is our podcast. It's also been turned into a, you can listen to the summary of our paper in English and Mandarin. So this is the URL. You can just Google telemedicine in Southeast Asia. So we wanted to know what the other countries are doing and how they are delivering telemedicine in their countries. So we limited ourselves to just Southeast Asian region. We share the same language in a way. It's like Arabic in Saudi Arabia and the Egyptian Arabic. So the Malay papers were reviewed by Dr. Irma in Indonesia, and I reviewed the telemedicine guidelines in Malaysia, Singapore, Vietnam, and Thailand. So we collated our findings. This is Kuala Lumpur. I welcome all of you to come to our country. This is the Twin Towers KLCC. Kuala Lumpur Convention Center is here. And this is a city view of Bandung in Indonesia. Okay, so what we did was we just looked at all the advisories, the guidelines, acts, law on telemedicine up to 2020. And out of the 5 countries, we limited because we didn't include Philippines and also Brunei, mainly because Philippines had their own representative for the World Federation Neuro Rehab, Tele-Neuro Rehab, Special Interest Groups. So my job was to review Malaysia and the neighboring countries. So we selected papers in English, Malay, and also in the Indonesian Malay languages, and used only 3 search engines. And there were 3 reviewers, and we based our audit in a way, scoping review, on Maurice Marr's paper, WhatsApp guidelines, what guidelines, a literature review. So this is the URL for our paper. So out of 62,300 papers, we screened it. Only the first Google search were included because after 100, it's all nonsense. So we removed about 62,000 odd, and then it left us with 68. Now out of this 68, we excluded those with no mention on telemedicine guidelines. So out of 24 papers we found, that we had to, this is by the reviewers, they said, why not you classify the guidelines into clinical, ethical and legal, and operational and technical. So what we found was the most papers were churned out by Indonesia, and this was during the peak COVID region, era. So a lot of papers, or how do I say, it's a gray material, like advisories from the Malaysian, the Indonesian medical councils, and everybody had to come up with some regulation because nobody knows what to do basically in COVID. So based on Maurice Marr's paper, the WhatsApp guideline, So we divided into three main themes. So most of the guidelines in the five countries that we reviewed had mentioned the definitions of telemedicine. So the best, in our opinion, the Singapore national guidelines was the most comprehensive. And this is because I think it was written or formed not solely by the Ministry of Health. So the Singaporeans came up with this national telemedicine guideline. It's a collaboration between the public and the commercial entities, universities, as well as like the Medical Act, Devices Act authorities. So, sorry. Yep. So that's why they had more, they ticked more of the boxes. Okay, so the second one that all the countries mentioned about was clinical governance. You know, how do you regulate the health practitioners? But the thing is, we found that the pitfall of this is when you want to come up with guidelines, you also have to consider if the practitioners' clients, they come from outside your country. Because as health practitioners, you are bound by the land, the law of the land. For example, if I am a doctor in Malaysia and my client is in Saudi Arabia or like Riyadh probably. So if I do anything wrong towards this patient overseas, like in Riyadh, then I am not subjected. I'm only subjected to the Medical Council of Malaysia, not Medical Council of Saudi Arabia. So we realize that all these guidelines, it's very loose. You don't have trans-regional boundary data sharing laws on that. What is the limit of your privacy, like patient's privacy, the records. Does the patient know that you're actually sharing their private information? Sorry, it's Chinese New Year here, so you're going to hear a lot of firecrackers. And then what else did we find? Yeah, the clinical governance is mainly regulating the doctors. Not much was mentioned about nurses or allied health practitioners like physiotherapists, like speech therapists, So after COVID, the post-pandemic era, I think more countries such as like India and Indonesia, they are very comprehensive. They are very inclusive. So they cover not only the doctors, and not only the nurses, but also the allied health practitioners. What else? Restrictions. So yes, these restrictions, some mention, when I say yes, it's mainly the doctors. Okay, mainly, okay, you can do this, but you can't do this. But there are a lot of loopholes that maybe you guys are surgeons or GPs. I'm sure you can name a few things that that's not covered by the law of the land. Thailand at that moment, during our review up to 2020, 2020, we stopped at 2020, but also 2021 because there's a lot of guidelines that came out after that. It's about the restrictions about billing, about what kind of discipline, what kind of procedures that you can or cannot do remotely, right? And then, yeah, in Vietnam, the definition of telemedicine is if it's like, it's mainly geographical. So if it's like outside the district hospital or health center, then you can, because you want to save the patients from traveling. But we now know, learning from COVID pandemic, and now endemic, yeah. So we know that it's not geographical. You may be even in the same building, but different floors. So you avoid the face-to-face contact. So we need to review and standardize. So if the Saudi Arabia government want to come up with the telemedicine guideline, must think, when you say restriction, what actually do you mean? Is it by discipline? Is it by geography? Is it by billing, private, government? So that's something for us to consider. International service is also the same, because it all depends on your definition of telemedicine. So if you say, oh, all online consultation is considered telemedicine, okay. So what does it mean? What about WhatsApp? If a person is just asking opinion, do you consider that as a teleconsultation? So you really have to tighten all the screws. Medical ethics, I mentioned earlier about the limits of your medical councils, regulating bodies, legislation. At the moment, Malaysia is reviewing its Telemedicine Act. We haven't done anything because the clause 9.2 says can't charge patients. So now we are having an economic crisis. So honestly, in my hospital, the barriers towards telemedicine is great, because we can't charge patients. So nobody's interested in telemedicine, in all honesty. The administrators are not happy because we're not collecting money, but then patients can't come. There's no parking at the hospital. So we all know telemedicine works, but it's in the patient's best interest, but not the government or the Ministry of Finance best interest. So we still have to sort that one out. And then, like, if you want to charge, so based on what fee, which guideline? Because Singapore they've sorted this one out. Even Indonesia have sorted it out. Thailand have sorted it out, especially in health tourism. They also have the telemedicine component of it. So Malaysia has to really back out in that sense. Confidentiality and privacy, I mentioned before. This is hard, especially when you want to do teleconsults, telereferrals. Does the patient actually, when the patient gives consent, what is considered consent? For example, does the patient know when he or she is consulting a doctor, and if that particular doctor is not sure or wants an opinion from another center or another discipline or another physician or a few team members, that's kind of like difficult, because does the patient know that it's going to be like more than one person will know this case, So you really have to think, patients are getting smarter, and just one misstep, you can get into a lot of trouble if you don't spell out what is the boundary of your confidentiality. What else? Okay, so these IT issues, like identification, passwords, logins. Yeah, it's kind of simple, but people can hack, especially in medical records. We now have a problem with our My Sejahtera. So during COVID, everybody needs to scan this QR code, okay, and declare, all right, I don't have COVID symptoms for the past 24 hours or 1 week or whatever. And then there's a dispute, because the developer of the app wants money. And then the government saying, okay, but the patient is basically Ministry of Health patient. So there's a dispute in the data stewardship, like who owns the data? Is it the Ministry of Health or the vendor or the developer? Like, actually, who holds the baby? So you need to really spell out basically who owns the data, because when you want to do something, oh, I agree. Actually, you really read from top to bottom what you are agreeing to. half of the time you don't. You just want to get to the next page, isn't it? And they force you to say agree. Otherwise, if you don't agree, then you don't get the next button, next page, and you can get the clearance. Okay, so the next one is data security. Okay, I mentioned that one. Record keeping. Okay, this is very important. So when we reviewed the data storage, okay, this is a problem, especially in a center like my hospital, for example. So if the IT says, okay, please clear your desktop, we are going to like do a maintenance. So whatever data you have on the desktop needs to be backed up. So where are you backing it up? Are you backing it up on the IT of the iCloud, or even external hard drive? How long are you going to keep it? So Vietnam, I think they actually mentioned in their telemedicine guideline that they are supposed to keep it, I think, I'm not mistaken, 5 or 7 years. And it's like to the last detail, like how do you get rid, how do you keep your patient's data, how long and where. So if you want to trace it back, so the audit trail must be, you must be able to go both ways, to and from. So I hope you understand what I mean. Like if you want to get rid or delete the data, where is the data being kept as a backup, right? Okay, licensing, yeah, you can come up with a lot of acts. You can say, okay, you need to go to this department to get your app being approved. And after you have used the app, how is the data going to be handled? Like, are you going to sell it to the pharmacists? Are you going to sell it to the insurers? And if you, are you allowed to do that? Does the patient allow you to do that? So those kind of details need to be spelled out when you are doing anything about licensing, especially with all these gadgets, there's this Internet of Things, when you are measuring bio data, like, like pulse rate, or how people feel, or when you're surgery, the pictures or the videos, when you're doing a scope. So the camera, okay, fine. The video that you have taken, where are you keeping them? And does the patient have access to it? You see? So because it's the patient's data, right? Okay. In our culture, especially Southeast Asia, we use a lot of traditional and complementary medicine. Whether you like it or not, the patients will go to TCM first before going to you. Or they are doing both. They see you and then they'll get a second opinion. Or the first opinion is always this TCM, traditional and complementary medicine, and then they come to you. So we realized that if you can't fight them, you have to join them. So in 2020, I think we still haven't come up with a proper telemedicine guideline per se for TCM. I'm not sure how it is in 2024. I have to come back to you tomorrow if there's a slot for me. But Indonesia, top marks to them. They know, they use it a lot. The word is majung. Majun is it's an Arabic word, right? It's naini majun. So it's they use a lot of they regulate basically TCM. Thailand and Vietnam up to 2020, there was no mention about telemedicine guideline for the TCM. Okay, ICT. Okay, ICT is very well, everybody mentioned about it, but what kind of policy? So in Malaysia now in 2024, we are trying to roll out 5G. At this stage, we were just testing the 5G bed. So a lot of development, this needs to be updated lah. So maybe I can come up with the paper, the updated version of this telemedicine guideline in the ICT infrastructure. Internet speed, okay, have to say, In Malaysia, we have a lot of disparity, especially in the mountains, because we are not all of us live on beaches. So there are the mountains, especially in district hospitals. So you can say, oh yeah, we're rolling out 5G. Yeah, great, great, great. It's usually in the Klang Valley, okay? It's like a Silicon Valley. But in the rural areas, they are not up to speed. For example, I also do community-based rehab in my old kampung is village, my ancestors' village. And that place, you can't even get WhatsApp. You know, the calls are very interrupted. So we still can't say, oh yeah, you know, we say, oh yeah, we do telemedicine. We can't do that. Because maybe you do telemedicine in big cities, but what about the regional areas? So you need to make sure that equitable. When you say internet speed, it's not just okay. I'm subscribing to or top notch of 500 um megabits per minute or whatever, you know. It's like you pay top dollar, but in reality you can only go up to maybe 30 or 50, you know. So must be honest and accountable when you want to say yes, we have telemedicine guideline outlining the internet speed needs to be minimum requirement or 20 or whatever. You check. You need to check, are you really doing what you are saying? Human resource, okay, this is the biggest barrier. I can tell you, in my hospital, it's a computerized hospital Sultan Idris Shah. However, because our old system, 2012, is 5.x, so now we rolled out in October 2023, 12.x. People are not interested to tele-rehab because they are very busy in just upgrading the standard of care system. So when you want to talk about, okay, I want to do tele-robotics, I want to do telesurgery, I want to do tele-dermatology, whatever you want to do, you have to check whether your human resource is ready or not. Because even though on paper, telemedicine is very good for your clients, very good for everyone, in reality, the paperwork is even more than your face-to-face. Okay, in reality. So this is probably the biggest barrier: human factor, human resource, training the new people, training the old people, the new system. Okay, that's one problem. Training new people, the existing system, another problem. And training want to change is another problem. So that's the human factor of it. Next is the cost. Okay, cost, like I mentioned very earlier just now, we are not charging patients. We can't charge patients because we do not have an act to say, hello, yes, this is the fee for telemedicine. And not, we haven't even reached insurance. Okay, insurance not paying. There's no code for telemedicine. So there's a lot of problem there. A good example, if you want to emulate, is Australia. So Australia, because I'm also an Australian resident, the doctors or nurses or whoever, the healthcare professionals, they are incentivized by, if you are doing like more than 35% of your daily consult, like if you're a GP, your teleconsult, if your consults are teleconsults 35% or more, then you get a Medicare rebate. Medicare will pay you. So we haven't reached that yet. Okay. But Australia is a good example for you guys to look at. Reimbursement goes along with this costing, and feedback, this is good. Only Singapore bothers to ask about the client. Do you like telemedicine and all that? So the rest of the countries that we reviewed did not have that in their guideline. And choices, you are supposed to say to them, you know, okay, it is up to you, this is not a force and this is not compulsory. You have the options to opt out, or you want to make a hybrid system. You know, maybe the initial consultation needs to be face to face, followed by maybe 2 or 3 consults, and then you come back for a review. So everybody knows this one. What is telemedicine? All sorts of as long as your standard of care you just use a ICT interface, whether it's in text, audio, video, Internet of Things, gadgets, apps, then it's considered telemedicine. Just one example, okay? So we have a few private hospitals as well as government hospitals with a private wing that's doing surgery. Okay, what else? Okay, so this is the learning points. Okay, so in summary, most guidelines have clinical governance, so everybody knows how to regulate, because we don't want patients to sue us, basically. And in all the 5 countries, they have policies on data security, record keeping, patient confidentiality, ICT infrastructure. However, the pitfalls are unclear guidelines on the technical aspects like human resource training, ICT infrastructure, cost reimbursement. No clear guidelines on trans-regional data sharing, cyber law, and data stewardship. Okay, so mainly this is based on Carl Del Chico Francois. He's now doing his fellowship in Canada. So his paper mentioned about these 3 factors. So anything you want to do, whether telerobotics, teleconsultation, telephysio, teleOT, tele whatever, okay, consider these 3 main factors: human factors, technical, and administrative. So like I mentioned before, in my center, even though I'm the World Federal Neuro Rehab, whatever, special interest group, I can't move in my hospital because the main barriers would be the administrative. If people don't want to telemedicine because we are not charging patients, we can only charge them if they come to the hospital. Therefore, my hospital is always packed with people, sick people. And then the human factor is on the change. You're so used to their, a lot of paperwork. Got to do the pre-contact, contact, post-contact, data collection for the telemedicine. So there's just a lot of problems. Technical factors, yes, like I mentioned before, merging or transitioning to a new system, a new building, a new director, maybe. Yeah.
The presentation is about telemonitoring for surgeon, systematic review. And as we spoke before about the effect of telesurgery and telemonitoring, in the 21st century, there was a lot of pressure about health services. And in many aspects, the healthcare providers are taking care of providing more health services in remote regions. And COVID-19 was the trigger to promote this in many countries, including Saudi Arabia, because there was a challenges to promote health services during crisis time. And in that study, there was a major shift in the pattern of the disease, and that hypothesized for that study. And the surgery was likely to play an increasing role to treat patients either in acute or in a chronic stage. Of course, in a chronic stage, it is well known, but in acute stage, there is some debate. What do we mean by an acute stage? And we know that acute stage would require surgery anyway, but how can we do that in case of the patient is in a remote area? How to monitor that? Low and middle income countries take care of this new health modality. But again, in the last presentation, our well-known speaker discussed the limitations of the human resources and the telecommunication challenges. HR was a major challenge, how to put that in the normal figures. Centralization typically concentrate in a specialist surgery, and in high-income countries, although there is a major interest about telesurgery and telemedicine, but as far as we know that the will addressed or at least capitalized to be the major umbrella of health services for telemedicine and telesurgery. Over the last 2 and 3 decades, being a surgeon, the robotic surgery take the challenge, and they start to make the marketability more obvious for the robotic surgery as telesurgery. On many occasions, they promote the robotic surgery that if you have the council of the robotic surgery in New York City, you can perform the surgery in France, in Paris, and it has been done. Of course, there are many issues about the latency time, etc., etc., but it has been done. That was almost 2 decades ago, and since then they make the marketing plan for the robotic surgery as a modality of telesurgery. Unfortunately, over years, the robotic surgery take over, and there is a major misconception even in the literature about robotic surgery. It's becoming as a default for telesurgery, and actually it is not. The telemedicine is a modality that has a potential to help and face these challenges. Telementoring in particular provides unique solution to increase both quality and access to the surgical care. And again, we go for a very common example of the telementoring, which is the intensive care unit. In many hospitals, as the previous presentation, our last speaker, she mentioned that there is one physician, he handled over the monitoring area, and he is supervising many locations in one location. So what is next? Telemedicine has previously been defined as the use of medical information exchange from one site to another via electronic communication to improve the patient clinical health status. And again, if we go to analyze this definition more, the medical information exchange, where we go to the legality, at what part the medical information can be exchanged, and what are the limitations, and who is accountable for the pitfalls of this. Is it the facility, or is it the physician or the surgeon, or is it the IT personnel? So who is accountable for that? And who is accountable to hold the data, and for how long? That's why we need more regulations about this. And most of the time, the definition reflects what is behind. So 6 studies reported that there was associated cost of their telementoring setup, and reporting the cost was heterogeneous throughout these studies. And in one study is reported one-off cost of $2,750 for a self-created low-cost system. Using readily available equipment, including personal computers and laparoscopy stack, and a video capturing system with a free video conference software. And actually, this is one of the, I would say, economic way of doing such telesurgery and telementoring. And it can be done this way in many countries because of getting exactly to the hardware and putting away the software in a limited space. As you know, in many e-health system, one of the major challenges is the update cost. Most of the companies, the international companies, they provide solution, but we face at one stage some challenges in making payment for company X or company Y to provide the update for the software. So what is the cost of the telesurgery? As we spoke, there is a direct cost and indirect cost. And the direct cost is defined in the finance that the cost, which is obvious and clear that you pay it immediately, like the travel cost and the consultation bills, etc., etc. But there are indirect costs like the property, the land, the infrastructure, etc., etc. These are not counted in many occasions, but again, it has a rule, because in some countries, the indirect cost is too big. So it affects the end, at the end, the bill of the patient. So in one study, as we spoke in the last slide, that the laparoscopy stack and the video capturing system, it costs something like $2,750 US. In 7 studies showed that there is no difference in the outcome. One found that telementoring was subjectively rated as an inferior to on-site mentoring, and 3 of them found that telementoring had to a prolonged operative time, which is a disadvantage, should be the other way around. And 1 found that telementoring to be superior to on-site mentoring. Robotic assisted laparoscopy. This is an example of radical prostatectomy. Mentoring techniques were clinically compared and showed no significant difference between clinical outcome for telementoring or on-site mentoring. Another study of the efficacy on the on-site versus telementoring in robotic surgery found that on-site mentoring was preferred by trainee. 12 separate studies directly compared telementoring against on-site mentoring, as we spoke that there are variations. Free text analysis of the trainee response determined that the reason for this difference was because mentors were unable to demonstrate movements with their hands during telementoring. Multidisciplinary studies comparing clinical outcome have shown that no difference between telementoring and traditional mentoring outcome. Assist included operative time, blood loss, post-operative pain management, time to recovery, hospital stay, and complications. But those studies, they did not focus about the human resources needed. And the telementoring will provide lower need for multiplication of the manpower in each hospital, because you need to monitor by one station many locations in different hospitals. So if we go in more deep, we may find that telementoring is have its own abilities to provide lower cost and higher level, and Ministry of Health in Saudi Arabia are already doing such with the intensive care unit. Because of lack of the manpower, the highly skillful manpower, they are providing such solution through telementoring in different locations. There were no major complication in both groups and no significant difference in the operative time. And in the 3 studies that identified the difference in the operative time, there was no statistical difference. Both modalities significantly improved the task performance and economy of the movement, with no significant difference between either modality. The augmented reality telementoring, ART, use an overlay of the mentor instruments into the trainee screen. And the augmented reality telementoring is considered one of the new modalities that should take action, and especially for the surgeon, because you can do more realistic mentoring for your staff. Another study showed that the ART reduced time taken to complete the task from other course, like the fundamentals of the laparoscopic skills. And it didn't, however, affect the number of errors committed by the participant. This is very important for the surgeons, because we're trying to minimize the errors and the technical mistakes for the surgeon, as we do many times courses and workshops for them before they commit their training on patients. So the ART, the augmented reality telementoring, is an essential part of the training for our staff, either nursing or physicians. In the pediatric trainee surgeons within their learning curve, when telementoring using teleillustration had reduced operative time, length of the hospital stay, conversion to open, and post-operative complication rates were compared to unmentored cases. But again, we have to focus again on overall complications because the bariatric surgery, the high skilled surgeons will be able to protect the patient during an eventual event. In many occasions, what you call it a good luck for the team or for the patient will pass through an eventual course, and the patient will be able to overcome the challenges that may happen during surgery. Another studies compared the telementoring against complete absence of mentoring and found that 75% found outcome demonstrating benefits as a result of telementoring. So, and those studies, it has shown that telementoring is important for providing such step. So if we compare the cost effectiveness in a resource poor setting, it was found that telementoring using AV increased the FLS performance score of telementoring participants in comparison with those who learn via self-practice. If we compare the Google Glasses, when used in a simulated field to allow mentor to visualize the trainee view, helped the mentor reduce the main composite error of the trainee carrying out the task. And this is important to monitor and to see how do we perform in such issue. And it is very important because of the trainee all the time would prefer to have some supervision by their trainer. And the trainer all the time, especially in the surgical procedure, would like to supervise his team step by step during surgery, especially in the critical steps. Telementoring improved confidence in trauma surgery, treating acute bleeding in simulated environment, but there was no significant difference between remote telementoring via AV assistant or performing the simulation without mentorship with regard to blood loss. And again, we should not be overemphasize this fact, because there are other facts that should be considered during this, because we can put a major control over that, and we compare the result of the control over most of the complications that we see in trauma, like the morbidity, the mortality, the wound complication, the requirement for the ICU, the requirement for the antibiotics, etc., etc. So we should not focus only on the blood loss for assessment of the mentorship. For remote surgical operations, which require both rapid and accurate transmission of information, and again, the lag time is very important in such conditions, the factors that influence the rapidity and accuracy of this information are the time required to convert video images and gestures into electronic signals, and the bandwidth and time lag of existing telecommunication lines. Using current technology, we recently showed that the feasibility of performing remote surgical operations in experimental animal model. The experiment result allowed to perform for the first time remote robotic surgery on human, as we explained before, that robotic surgery has been advertised as a tele-mentoring or telesurgery device. At present, the post-operative course and discuss the current limitation of the potential clinical and social impact of remote telesurgery. So if we go to monitor, what do we have for patients? This is an example of a woman, elderly woman, whose history of recurrent abdominal pain in the right hypochondrium and epigastrium, underwent abdominal ultrasound, documenting a gallstone, inflammatory gallstone. And there was no dilatation of the common bile duct. Laboratory finding showed normal range. The patient was scheduled for laparoscopic cholecystectomy after approval of the ethical committee, and the patient gave her informed consent to the operation. So using the robot setup consists of two physically separated subsystems named surgeon side and patient side. The surgeon's subsystem based on New York and the council that take a patient, and the patient subsystem based on Strasbourg include two robotic arms that translate the input into actual instrument manipulation and an additional robot arm to control the endoscopic camera. And again, the timing, that was almost 2 decades ago, but again, there was a major question about time. At that time, they utilized the satellite transmission, and the lag time was almost acceptable. But currently, the lag time which is acceptable nowadays should not exceed 0.2 seconds. The variety of surgical instruments can be connected to the robot arms so that the surgeon can activate grasper and so forth by simply manipulating the handles at the remote console. Two computers connected by the high-speed communication channels linked the two subsystems, and the camera movement were directed from the computer in New York according to the operating surgeon instructions. So the connection between the two cities were established through asynchronous transfer mode, ATM technology, and the network nodes are interconnected through a high-speed fiber optic network that transport data through virtual connection dedicated per customer. The ATM network provide a high-quality service for data transport. And for instance, the probability of having no network outage is 99.99%. The ATM network provides low transport delay and low packet loss ratio. And again, the low transport delay, this is very important because what we need is almost like an actual operation without interference by the telecommunication itself. The virtual pathway using ATM technology was set between the equipments of the presence in New York and the operating room in the Strasbourg. A bandwidth of 10 megabytes and has been served through the network connection application at the site using a network termination unit. To monitor and measure its own level of quality, the NTU, which is the sender, inserted operating and maintenance packets within the user data flow, which has extracted and analyzed by the remote NTU, the receiver. Analyzing these packets and comparing the number of user packets initially sent to those actually received, we measured the number of lost packets. An identical backup line was available in case of main line congestion. Data flow assigned to each application merged into 10 megapixel per virtual path according to specific quality surface. Data coming from those two applications were merged and received guaranteed minimum rates of around 3 megapixel per second, 3 megabyte per second. Video packets were sent to the minimum guaranteed rate of 7 with the possibility to use more bandwidth if available within the 10 megabytes virtual path. We have plugged a video conference system and intraperitoneal phone to NTU. The two sites were also connected through a video conference system and a large television screen at both sites. The operator site was set up in the non-medical building in Manhattan. Surgeons in New York performed the dissection of the cystic duct and artery and the cholecystectomy, while a team in Strasbourg induced the pneumoperitoneum and performed robot arm setup, trocar placement, exposure of structure, and clip application. In Strasbourg, the surgical team monitored the procedure on a screen and was in the constant connection through the phone line with the colleagues in New York to coordinate electrocoagulation. After completion of the dissection, the introduction of plastic bag for extraction, the gallbladder was then removed by the surgeon beside. The abdomen was then exfoliated and the incision was closed. And the operative steps were carefully monitored, and technical difficulties, complication, appropriateness of dissection, and operative time were recorded. Evaluation was 0 to 10 scale. Each surgeon was unaware of the colleague's evaluation. So the robot arm setup and trocar placement required 60 minutes. The laparoscopic cholecystectomy was performed in 54 minutes. And this includes the time lost for switching the instrument at the robot arms for different steps of the procedure. There were no complications. Coordination of electrocautery as ordered by the surgeon in New York were excellent. There was no damage related to the use of coagulation. No bleeding occurred during the surgical procedure. A reproduction of image details on the video monitor at the operative site in New York was highly accurate, resulting in perfect visualization of the structure. For the duration of the operation, however, there were no interruption in the transmission of the surgical movements or degradation of the video signals. The constant time delay was 155 milliseconds through the procedure. It has been found that no ATM packets lost during surgery, and the subjective evaluation quality of images by surgeon had average score of 9.5. The overall safety of the procedure, which is again a very important issue, was intended as the combination of high-quality video images for appropriate visualization of the structure and anatomical details, ability to control surgical movements, and perfect coordination in the use of cautery for coagulation of vessels. All three surgeons rated as 10 the score of perception of the safety of the operation. This reflects the confidence of the surgeon and the reliability of the total system. In no instances throughout the operation was there any risk to the patient related to the teletransmission or the use of robot system. 2 and 4 weeks after surgery, the patient was seen in the office by the surgeons. Her wounds were well healed and no signs of infection. At the time of first visit, she was already back to routine daily activity. Pathology examination of the specimen documented the presence of chronic cholecystitis and 4 mm benign polyp in the gallbladder mucosa. The robotic system have a computer program that filter out hand tremors. and the chair arm at the surgeon console had stability and comfort during procedure, improving the endurance. But we should not overemphasize this fact too much, because not all surgeons has a trimmer already. Again, it is important issue, but it's not that major issue. The fixed posture of the surgeon lead to a fatigue, and turn further increase of the tremor and unwanted movements. Again, this is a fact that it should not be overemphasized, because surgeons many times they spend hours during surgery. So doing 1 hour surgery is not a major issue. And again, the issue of the fatigue and the tremor should not be overemphasized. If working against or with image magnification, laparoscopy, or microsurgery, the surgeon tremor is an important part, but again, this is not always the scenario. The devices that cancel physiological tremor have been used vitro-retinal microsurgery. The robotic system have been used for retinal vein cannulation with a needle for administration of local therapy for retinal thrombosis. This involved cannulation of 100 millisecond structure. These features and possibility of modulating the amplitude of surgical motions by downscaling and stabilization translate into smooth and precise surgical maneuvers. Enhanced dexterity is suitable in multiple instances. So what are the clinical implications? The group performed laparoscopic robotic cholecystectomy in 25 patients with no robo-related complications, with operative time and patient recovery similar to those of conventional laparoscopy. It has been reported a series of 146 patients undergoing robot-assisted laparoscopic surgery, including anti-reflux procedure, gastroplasties, cholecystectomy, inguinal hernia repair, hysterectomy, and prostatectomy. A robotic assistant has been used for laparoscopic nephrectomies and laparoscopic radical prostatectomies. Also has been facilitated the endoscopic cardiac surgery, including coronary artery bypass and mitral valve repair. Current efforts aim to provide the capabilities to perform surgery on the beating heart through the motion compensation, which would allow the surgeon to operate on any moving structure with the same precision as if it was perfectly still. There were no complications related to the system, but the robotic assistant was found to be most beneficial when microsuturing within the abdomen or very confined spaces. There are several challenges involved, but the most important limitations have been the reliability of the telecommunication lines and the issue of latency. And due to the latency factor, it was believed that the feasible distance for remote surgery was no more than a few hundred miles over telecommunication, and geosynchronous satellite system, which have a latency nearly 1 seconds, and considered unsuitable for performing long distance surgery. The current research estimated that 300 milliseconds was the maximum time delay compatible with safe performance of surgical manipulation, and the mean time delay of 155 milliseconds over transocean distance was using dedicated ATM fibers. And the case reported here that the world first human long distance operation show feasibility and safety of performing a complete surgical operation from a remote location. There were no specific difficulties or complications resulting from the use of teletransmission of surgical procedure. These results support the use of existing high bandwidth dedicated telecommunication lines for performing intercontinental surgery on humans with adequate efficacy and safety. The technical feasibility and clinical safety, however, are not the only issues to solve to permit implementation of telesurgery procedure into routine clinical practice. The use of remote telesurgery will depend on a balance between a real benefit and limitations. There are several limitations. The backbone, which is the high speed of the ATM fibers, is present more than in 200 countries worldwide. Currently, most hospitals are not equipped with ATM technology. That was the performed surgery in the office for our partner company of the telecommunication rather than a major US hospital as planned. The cost of remote operations may be a reasonable concern. The robotic mechanism costs approximately 1 million. And again, nowadays, I think it's approaching 2.5 million. For the current research development, other significant costs involve the use of telecommunication lines and human resources, including several professionals such as surgeons, computer scientists, and engineers. The cost of remote surgery, when performed on a routine basis, would have to cover solely the cost of robotic machine and teletransmission. The remote surgery applications will benefit from robot-assisted surgery are multiple, but again, we have to count how feasible is that and how much does it cost. In my opinion, it's getting higher and higher over the last 2 decades. So I think we may reach a stage that it is not feasible anymore. Any patients can receive a form of treatment more appropriate for his or her condition or more advantageous, such as a new minimally invasive technique. This may have even more profound impact in the developing countries, where healthcare is often provided by volunteers who do not necessarily have expertise in all fields of medicine and surgery. Again, as you can see here, that is doctor or the physician, he's in one area, the surgeon, I mean. Let's say he's in Singapore and the patient is in Africa. And there is a forward link and feedback link. So there will be an audio visual system and remote control and haptic feedback data. Again, we have to be more realistic. If the surgeon is in Singapore and he has the facility, it is not a must to have it in the same or on the other side of the continent or the country. Emergency operation in a small rural hospitals are sometimes challenging for young surgeon, and the variability of network connection to the hospital to a major center would allow expert surgeon to assist or carry out the procedure themselves. In addition to all these potential advantages for the patient, active intervention from remote location open a new avenue for surgical education. The objective of performing a remote procedure is not, in fact, to replace surgeons. It can improve surgery through teaching and mentoring to reduce learning curve of surgeons. For the new procedure, various degree of interaction between the expert and the surgeon at the bedside are possible. Assistant for expert may range from complete performance of the procedure to help just with exposure of anatomic structure to facilitate the work of the surgeon at the bedside. So we believe that by enabling the direct intervention of an expert, remote telesurgery will likely reduce the errors that are caused by the lack of experience or related to the early phase of learning curve of a new procedure. As a result for this potential impact in training and education, the teleperformance of surgical operation require the expert surgeon to be familiar with robotic devices. Simple expertise in a particular procedure or disease would not be sufficient to provide active support. At present, there are not enough surgeons specifically trained in robotic surgery and remote performance to contribute to the implementation of telesurgery. There is no doubt that remote telesurgery depends on robotic assistant and information for such issue, and technologies are already there, and therefore they cannot benefit, or they can benefit from the future development of robotic technologies and implementation of virtual reality and simulation in the surgical practice. Rehearsal of surgical procedure might be optimized as a stored data set of movements with false move eliminated, and the perfect surgical procedure delivered by computer-driven and computer-enhanced robotic arms. The enhancement of human dexterity resulting from the use of robot and performance of high precision tasks from a distance may have other advantages that extend beyond surgery. In conclusion, the remote assisted telesurgery is feasible and safe using designated ATM telecommunication line, and we have to focus on the latency period, which should not exceed 0.2 seconds. And the possibility of performing complex manipulation from remote locations allow an expert surgeon to teach the performance of advanced or new techniques by the real-time intervention and actually eliminating geographic constraints for obtaining high surgical expertise. Thank you very much. Any questions from the audience? أي سؤال يا أخوان؟ Any question from the audience? Thank you, Sarab. Noor. Cost will be more. Yes, of course, cost will be more. Yes, agree. Muhammad, Salah, thank you very much. Alia, thank you. Result same. Well, this is maybe yes, maybe no. Thank you for reading. Thank you, Daniel. Abdul.
Read the abstract?
No, just proceed, please.
Okay, thank you, ma'am. It's my pleasure. It's my pleasure. Okay. Let me give some brief introduction on the mental illness and disorders. Mental illness is the unstable mind which can lead to an unhappy and unhealthy, non-productive life of our society. So in most of the cases, we people do suffer some sort of mental disorders. There are so many causes, so many reasons behind that for having unhappiness, such as anxiety, stress, unhealthy lifestyles, mood swing, unbalanced diets, some genetic problems, hormonal imbalance, and moreover to that, during the COVID situation, what we have observed that due to frustrations, work pressure, breakdown, lockdown experience, we have almost all of us have suffered from some sort of mental disorders or mental problems, and we need to address those things. So, what are the different advantages of telepsychiatry? Telepsychiatry means the patients can communicate their problems, their feelings with doctors with the help of computers, internet-based apps or laptops, so that the geographic barriers do not fall into this category. The costs can be curtailed. There are so many advantages of that. That means the remote, first advantage is the remote benefit. Remote treatments, patients can get their benefits from remote locations. Protected data transmission. In any online telemedicine or telesurgery platform, what is the most important thing is that you need to take care of the patient's security data. You need to protect those data. Those data are most vulnerable to the attackers. So what we need to protect themselves before transmission. From the sender's end, we need to protect those data so that the inside intruders who are residing inside the communication path, they do not steal the information. If they steal so, they are unable to predict what we are transferring. We need to make some protected data transmission. Expert opinion can be received through online mode of telepsychiatry, because from any part of the world, the patients can get their expert opinion from their psychiatrist. COVID-19 minimization, it was also very much important during the COVID-19 due to lockdown restrictions imposed. COVID-19 can be minimized so that the people are not going out of their homes, so the COVID-19 can be curtailed in during that period also. Yeah, obviously low cost treatments. Let's say low cost treatment because the cost of the treatment is very low. You don't need any higher traveling costs and other investigation costs in case of psychiatric treatments, offline psychiatric treatments, those can be reduced. What I have made over here is the comparison between the telepsychiatric online treatment and a psychiatric offline treatment. First particular is that mode of treatment. Mode of treatment in telepsychiatry, what we do is usage of digitalized tools. We use internet, routers, laptops, apps, computers, ICT-based digital media, so that the patient can come and get their treatments from remote locations from their doctors. And in case of psychiatric offline treatments is the traditional method, so that we used to visit the OPDs or the hospital chambers for getting the face-to-face treatment. Cost incurred in telepsychiatry, the cost can be reduced, as I told in the previous slide also. But in case of offline treatment, the cost can be reduced or is much higher than the online cost. Time needed, yeah, obviously, the traveling time and the other times incurred can be reduced in case of online treatment, but the time needed is very much in case of offline treatment. Demography is a global access from any part of the world, and you can get the treatment services. But in case of offline treatment, it's a local access only. But that means suppose a person from China, patient is from China, if he wants to get some medical advice from India, it's very difficult for him or her to come physically and to get the such treatment. But in case of online treatment, they can get the services, remote services from through online survey apps also. Flexibility, high flexibility. Online treatments are more highly flexible when compared with the offline treatments. They are that means the OPD time and the venue is being fixed. They can't be changed. The flexibility. Communications and collaborations are done only through the online mode. But in case of physical offline treatment, now it is done only through the physical mode. Facility provision, it's asynchronous, and in case of offline mode, it's synchronous. What is asynchronous means that while having a session for the online treatment, the data transfer can be asynchronous. That means at any point of time, both the participants, both the recipients can share their views, share their opinion, irrespective of their feedback. But in case of physical treatment, it's a synchronous mode. In case of traditional treatments, it's a one-to-one question, and then it's a total procedure is synchronous procedure. Pace of the treatment is speedy. Online treatment is very much speedy, and offline treatment is very much slow. Okay. Now I shall discuss the computer related terms, that is the cryptography. Cryptography is the branch of science which can be used to protect any kind of data, so that across the networks the data cannot be leaked out. If even if the data is being leaked out, the intruders that who are residing inside the communication paths, they are unable to detect the exact pattern. That means you can see in the slide the plain text, that means the data which we are trying to transfer, it will be encrypted with some session key that I will explain what is session key, and it will become the format that we get is the ciphertext. And in case of through that ciphertext, it's an unreadable format, so that the intruders or the hackers or the malpractitioners they cannot recognize that pattern. That is the part of the encryption algorithm part. And in case of decryption, it's a totally inverse process. So while the recipient decrypts that ciphertext with the same key, and to so that the plain text or the plain data, original data can be retrieved out. What is the key or the secret key or the key or the session key? All terms are almost synonymous over here. I'll be using in this lecture. In case of the key is the something lock and key in our real life. That means if a key is being used, we use that key is for opening the lock and closing the lock. That is the key. That is the key concept. Here also we get some message, or we can data, or we can generate some string that will be used for encryption and decryption. I will explain through machine learning what I have done to generate the key. Encryption, what I told, decryption also I told that encryption and decryption both are the reverse process of each other. From the sender's point of view, encryption is being done, and from the decryption, it's the recipient's point of view. Symmetric key cryptography, what do you mean by symmetric key cryptography? In symmetric key cryptography, what we get is a same key will be used for the encryption as well as from the decryption. It's very there are so many advantages. Most of the important is the simple and fast communication, but it's less secure. Why it's less secure, I'll tell in the next slide. What are the different challenges, existing challenges in the telepsychiatry that needs to be addressed? First is the lack of data authentication and confidentiality. Yeah, obviously, whether the patients are a truly genuine patient, the doctors cannot authenticate. They are unable to have their confidence. Excessive use of online medical transactions during lockdown periods. Obviously, during the lockdown period, most of the treatments were done on the online platforms, telemedicine platforms, except the invasive surgeries. So there was a huge pressure on the online platforms, online telemedicine platforms. Spillage of such significant clinical signs may prompt abuse and false medical claim strategy, repayment issues where there are so many false repayment and false persons involved in those in this domain. They use those data and they claim the medical false medical policies. Similar key, session key or secret key can be used for multiple transactions in case of telemedicine. That's not fair. So that the same, if one session is being hacked, all the sessions will be hacked. The intruders will get all the session data if we use the same key for multiple sessions. Extensive use of digital platforms on COVID-19 without proper security. In most of the cases, the world was not aware of the COVID-19, and we were forced to serve the society. Doctors, especially people know better than doctors, were forced to serve the community mostly on the telemedicine apps platforms, but the security issues were not addressed properly. There were so many loopholes that those loopholes are to be addressed out. Robustness of the session key in terms of its fitness, the key that were used during those platforms are not fit enough to be used over here. So the fitness or the robustness of such keys should be standardized. Ciphertext that I told in the previous, what is ciphertext? Ciphertext may be prone to myriad attacks. There are so many attackers residing over the channel. Such attackers need to be, they are sitting over the communication path to steal those medical information from the patient. Public channel can be compromised. Even the patient node or the doctor's node machine can be compromised. so that the data leakage can be done. Sender receiver are likely to be compromised, what I told just now. Slower functioning of the COVID-19 telemedicine. There, most of the telemedicine systems are not are not functioning within their time limits. They take little bit of extra time for performance. Those are the existing challenges and what I have sorted out for the online telepsychiatric system. The main problem, the central question of my thing is that what is the problem in key sharing? In case of symmetric key cryptography, what we need to share a same key to the recipient and the sender. That means the patient to the patient and to the doctor or the psychiatrist over here. So if during sharing, if the hackers can get that secret key or the session key, what will happen? Then the entire session will be compromised. The entire confidential data that will be transferred between the psychiatrist and the doctor will be totally be leaked out. So this is the central question and the central problem that we need to address over here. During the key transmission, the attacker can leak that secret key. It's very much vital. And if that key is being used for multiple sessions, the entire data will be leaked out for the total number of sessions that use that same key. User authentication, it's a very much a complicated problem. So in this figure, you can see here over here on my slide, A and B both are the sender and the receiver. For consider that the B is the doctor and A is the sender. And while transferring the key, E is the your intruder or the malpractices or the hacker that can steal the secret key, who is residing inside the silently residing inside the public communication pathway. This is the central question of my lecture today, and I will discuss how to sort out this problem also. What is neural cryptography? As of now, what I told totally it's a part of the cryptography. And what is neural cryptography? Neural cryptography means that we need artificial neural network plus cryptography. It's a neural cryptography. It trains the artificial neural networks precisely to encrypt and decrypt the information. Means we need to have some artificial neural network. It's a neural network what we all have inside our brain. The artificial neural network is a simulation of the nervous system, central nervous system that we have, and we need to simulate that. And a combination of the artificial neural network and the cryptographic engineering forms the neural cryptography. And this is the part what I will be explaining to generate the session key based on machine learning. Neural key cryptography, self-key generation. There are so many things. Self-key generation, the session key will be generated automatically. Neural networks have the capacity to learn themselves and produce the output. Then you can train the different artificial neural networks that can be trained to generate some sort of output. Neural networks need to train and test the data. Those data are to be trained as well as those data are to be tested also. The inputs are kept in its own network instead of another database. Instead of storing the things inside the database, the inputs will be stored inside the neural network so that the data transfer is being cuttled out. Minimize the data loss, obviously, and the fast synchronization can be done over here. What is machine learning? It's currently a very hot topic for machine learning. Machine learning is the capability of a computer to show intelligent human behavior. Means the machine can show some sort of behavior likes of human. That means the artificial intelligence. Means the machines have some intelligence. That is the machine learning. That is the language that being used over here. The networks will be trained so that it can generate some decisions can be made, as well as the previous speaker, Dr. Mohammed, was speaking about robotic surgery. Yeah, there also there needs machine learning and AI based robotic surgery. Machine learning is a subset of AI that creates computer programs that learn to do a specific task by building a model from many examples. One example was already being given by Dr. Mohammed in terms of surgery, AI-based surgery. It needs huge AI applications. Features are being fitted into the network, and so that the machines are being tested and trained so that it can generate some sort of decisions, or you can predict the output. This is the classification of the machine learning: supervised learning, unsupervised learning, and reinforcement learning. Due to shortage of time, I am skipping those terms over here. What I have used in my presentation today is the tree parity machine. Tree parity machine is the, you can see over here, this is the tree parity machine. It's a neural network, artificial neural network. These are the input neurons on the base layer. In the middle layer, it's a hidden layer, and this is the output layer, consists of only one node. You can see that in the nervous system, in our nervous system, in our neural system, we have input neurons, we have so many neurons, and those neurons ignite each other. There are so many chemical changes so that the decisions or the act being done by the human body. You know, you people are from those background, you know much better than that. And what we do over here is that we just simulate those nervous system and design our artificial neural system so that it can act like that. And with that neural machine on tree parity machine, I have generated one session key. This is my proposed method. Sorry. Yeah. Suppose key generation. How I have generated the session key with the help of tree parity machine neural network. Suppose this is the on the left side, two machines are there, two tree parity machines are there, one from the near patient's end, one at the psychiatric end. Both the TPM tree parity machines will be treated with same inputs, and if the same inputs are being given, it will synchronize each other. It will synchronize each other, and after some sort of iterations, it will generate the same session key. Word vector will be same, generated same in both the machines. And if we generate the same word vector on both the machines automatically without sharing the secret key, that means our problem is being sorted out or being sorted out. If we get that secret key over here, we can encrypt that data, our medical data, with that key, and the ciphertext will be generated over here, and the ciphertext will be again decrypted by the receiver end with the same key. But what is the good thing about that? That we don't need to share that key, because both the machines have already generated their secret key automatically by synchronizing their neural machines, or tree parity machines. This is the proposed method of my lecture. I hope I am pictorially I have able to make you understand the problem and the solution approach. These are the algorithmic part, that the simulations, how the heavier network will be sorted out. Different sort of equations are over there. I am not explaining those equations due to shortage of time. Experiments results were done with the Intel i3 processor, 2 GB RAM, 1 TB hard disk, Windows 10, and the Python soft computing language that I have used is the Python. Is a very current and popular language. There are so many results, varied results. You can see the length of the session key is being made 128, 128, 128. In all those iterations, the length of the session key has been 128 bits, and in number of input neurons and the number of hidden neurons were made different, and correspondingly, what are the different iterations are needed to get the same session key on both the machines are being showed over different tables. There are so many tables, 8 tables are there, result sections. TPM synchronization, this is the synchronization. The earlier was the synchronization number of iterations, and this is the synchronization time that is needed in millisecond. Histogram that is being generated by our on 2 different files on data, on psychiatric data, and the histograms were being generated over here. Sorting frequency, autocorrelation means the similarity what we are getting. Any there are no similarities can be generated. If you see the autocorrelation, that means from both the files we cannot have some similar patterns. This is the avalanche test and the strict avalanche test. This is the results that being obtained in our study. Brute force methods means to decode the session key by the intruders in terms of years is very much long time. It's a hypothetical time frame that we have found or we have calculated for different session key lengths. Conclusions. Moving on to my conclusion part. Machine-based key generation, but my proposed technique is machine learning-based session key generation. TPM synchronization, tripartite synchronization depends on the both TPM given in the patient side and the psychiatric side. Flexible secret session key means the length can be being dynamic. Any kind of classical cryptography can be used for encryption and decryption. That is being any kind of encryption and decryption can be used over here. Okay, secure data transmission on online telepsychiatry. Yeah, through this approach, the security aspects of the patient's confidential data transmission can be done over here. No exchange of the secret key. Yeah, that I told earlier also. They need not to distribute the same key to the sender and the receiver. These are my references. Thanks all for patient hearing. If you have any questions from the audience, feel free to ask me.
Thank you very much, Doctor. This is very impressive presentation. At least being a physician and health professionals, we do not have such knowledge and the AI and etc. Although things are moving nowadays for AI to optimize our work.
Yes, sir. AI
and
is a very challenging issue, and in healthcare domain, without AI, you can't move forward. Yeah, in the coming years, AI will boost up more. I hope so.
yes, yeah, I agree. But do you think that the AI and tele-mentoring or telemedicine in the future will have its own identity? Now, as you can see, it is integrated.
Yeah, sir. Yeah, very good
It
question.
is,
Very good question identified by you. Yeah, if we compare from the before 10 years back, if we see the 10 years back scenario, the AI-based machine learning-based telemedicine or the telesurgery have improved a lot. In the 20 years ago, being a doctor, you haven't heard the term robotic surgery. Am I right, sir? So,
yes,
yeah, it's improving. It's already day by day, the scenario is getting improved. But there are so many limitations, and already you have explained those limitations in your presentation that I am not explaining the lack of infrastructure. Main thing is the infrastructure. What AI-based telemedicine is not to replace the doctors. It's not about to just a substitute of the physicians or the surgeons, but the infrastructure what we are lagging more in basically most of the developing countries. It's a very challenging issue. Internet facilities, computer facilities, apps, computer engineers, software engineers, knowledgeable persons. These are the so many, and the main thing is the cost, monetary, financial assistance. There are so many limitations. If we can improve those conditions, I hope the scenario will get better. But in my personal opinion, the things will improve a little bit more in the coming days. But AI will have a big impact on the telesurgery and the telemedicine.
Yeah, absolutely. Any question from the audience? أي سؤال يا أخوان؟
From the audience, if you have any questions,
No, I think there are. Usman, Majid, thank you very much, all of you. Many articles has been published about how to change the cancer patients' therapeutic pathway during COVID-19 and how to implement the telesurgery and telemedicine for cancer patients, especially patients who are either pre-operative, not operated yet, or post-operative, where they require a follow-up and maybe chemotherapy or radiotherapy. So that was a great challenge during COVID-19. So we'll discuss now how does telemedicine and telesurgery would help for patients with cancer. Across the quality, cancer care remain limited to any rural and remote areas. And again, one of our main goals for telemedicine and telesurgery are the remote areas where they have difficulties. And as you spoke yesterday to Sabrina, that in Indonesia and in Malaysia, there are many places, remote areas, which require attention, but the challenge was the communication process. The diagnostic, again, is an important part of telemedicine and telesurgery, like doing laboratory, reading the result. Also, the radiologic nowadays PACS system is taking over. You can do the radiological assessment in one area, and you can read from a different location. Again, the same thing applied for the specimen, slides, pathology, even the blood culture and tissue culture. But again, if it's the time for surgery, what to do? Again, this is a challenge. We are not speaking here about robotic surgery, but we are speaking how to perform the surgery, the complex surgery in an area which is remote. And I presented a paper last year in Rome about non-robotic telesurgery, because it's not a must to have robotic surgery to perform telesurgery. Again, as you mentioned, Dr. Sabrina, yesterday, the definitions and the international guidelines will require some attention to take over. Again, rehabilitation and palliative care are the same. And the palliative care patients, most of the time, has already DNR label. And the next question, do you take him to hospital in case of cardiopulmonary arrest, or there is a deterioration, or you leave the patient at home and you monitor the patient by telemedicine and telesurgery? So again, this is a legal question. That's why it is important to have scientific societies that they study the new era of implementing the health system. In Saudi Arabia, there is a major shift from physical clinic to virtual clinic. And this, of course, will require some scientific society to study, compare to benchmark and to make advices or regulations for the decision makers or the policy makers. The technology is best used via consistent long-term application. And one of the most common uses of telemedicine is virtual tumor board. And this is already applied over a long time in Saudi Arabia, because many tertiary hospitals in Saudi Arabia, they have already collaboration with major institutes in the world, especially United States, maybe Germany and the UK. So this is not new, but again, it should be as one group or as one unit, and should be all assist. Again, the legality of the tumor board. Some members are from remote areas, so how to perform or how to make this legal. I know you take their advice, their opinion. They are not legally obligated to be official member of the tumor board, but again, this is important in the future, because in case of expansion, they believe there will be a great expansion in the coming decade for these services, the tertiary services. Nowadays in Saudi Arabia, we have the health clusters. There are more than, I believe, 15 or something like that. And each health cluster should take care of himself and should take care of their own patients, which means that there will be no more referral between hospitals. Each health cluster in Saudi Arabia nowadays should take care of their patient, and they should provide the most optimal care. Of course, it is very good in one aspect, but require attention in other aspects, because it needs more collaboration for the tertiary level instead of one or two or a few centers who have the capability to make international communication. Nowadays, I think they need to collaborate to each other. After the acceptance barrier, which is typically removed in both sides because of the convenience to use, the reduce travel and provide equivalent care, the business case for the technology depend on certain criteria. And again, I think the other challenge is implementation of the e-health system in the health cluster or in the hospital. The financial issue is quite critical, because the more sophisticated specification of the e-health system in the cluster or in the hospital, the more financial obligation and burden to be taken care. There was another study from Kansas Medical Center who showed the costs associated with delivering cancer care by video conference dropped from $800 US per visit in 1995 up to 250 visit, or less than 330 cost of in-person visit. But again, we have to be careful from these numbers, because I always say that if you are obligated to utilize one device or one technology, you are already in the prison of that technology, which means that if the costs get higher, you are obligated to go with that. And I believe in some countries in the West, they have a major crisis because of the inflation of the health system cost, and this makes a major challenge. If you choose something, you have to consider the cost and the future cost and the economic impact for your cost. It is, I would say that the robotic console 2 decades ago was almost 2 million riyals, which is almost like 500,000 US dollar. But nowadays it's approaching like 2 million US dollar. Of course, there are more sophisticated solutions, but the assumption that the newer technology will be lower in cost, this is not exactly accurate all the time. I believe we assume that it's over time will go down, but this is not the case all the time. The threshold of economic viability was reached when more than 200 patients per year were seen. And several studies have demonstrated that effective physician-patient communication can be experienced through technology-based consultation, although concerns have been raised that it limits patient self-expression and its impact on clinical care, which is infrequently reported. We should not consider e-health as the magic solution because it has already its own limitation. And we know that the e-health or the telemedicine would be suitable, let's say, for pediatrics, maybe for medical team, but for the surgical team sometimes is not suitable. Or I would say partially not suitable because you have to see the patient, you have to make the general assessment, put in consideration that many patients, either they are septic or they are cancer patients. So such deterioration could be rapid, and the intervention will require the physical presence of the surgeon. Other specialties like medical or the pediatrics, if there is a deterioration, the MRP or the most expert physician would be able to deliver advice over the phone, and the team who is physically there would be able to take over. But in other specialties, it's not the case, like orthopedic, obstetric gynecology, surgery. There are some limitations still now. Some physicians reported difficulties with the use of telemedicine, including the integration of the service into their daily routine, which means that if I see the patient overnight and I make my judgment as MRP, but in the next day I'm going to see the patient. So what would be my the clinical appreciation for the progression of the disease? Last night it was a remote decision, and now this morning it's a physical decision. Till this moment, there is no studies, as far as I am aware, that they compare the same physician judgment in remote and in physical assessment. So we have to consider this perception of the physician over such clinical assessment. The development in the telecommunication have an impact over the surgical practice and education in multiple ways, including tele-mentoring, tele-proctoring of the surgical procedure, telesurgery, which means operating on patient from a remote location, and teleconsultation. All of these are yet require some definitions. And as Dr. Sabrina yesterday mentioned, that we still lack the definition for some terminology that we have to make it precise, and that's why we need some standardization for the terminology. So what is tele-oncology? There was a discussion for the vision and the principle, and there was an agreement upon the telemedicine planning committee for using telemedicine and telesurgery to extend cancer care to patients in distant location. The main principle was that implementing teletechnology successfully require pragmatic selection of goals and methods on the basis of needs and resources rather than politics and publicity. Again, how to manage the need to have medical license in every state where telemedicine is practiced. And this has been mentioned yesterday by Dr. Sabrina. Where is the legal limitation of yours? I would say that last night I was doing consultation, and at that time I was in a different country, but this morning I'm physically available. So which is which? Which one is legally obligated to such clinical practice? Again, the billing and the clinical the legal and the policy, all these are barriers to use the technology. It could be a barrier and it could be a challenge, but again, could be an opportunity, because I would say that if we standardize, if we are sure about the outcome is good and the prognosis for such patients, the billing could create a new era of billing for telecommunication and telemedicine, and this can be practiced nowadays with the digital era. The legal, already the economics and international trading between countries, they have agreements, international contracts. So I would say this could be another opportunity for making collaboration between health systems in two different countries. Again, could be an opportunity for the clinical judgment between different locations, and there could be an I would say that a general rule or memorandum of understanding between two health systems in two different countries. So what are the recommendations for tele-oncology implementation? The central coordination to optimize integration and the individualized technology solution for clinical subspecialties, and should be equal in both ends, and phased approach for implementation and funding, referral policy agreement between facilities. So if the referral system is clear and there is an agreement already, this should cover any challenges in the future. Buy-in from the physician and patients, where the patient will be billed immediately at the start of the tele consultation. And we have to establish clear goals for connecting physician and patients internally and externally to improve access to cancer care. So it was anticipated that teletechnology will decrease the travel burden of stakeholders and improve access to cancer care. A series of advanced technology demonstration by clinical faculty relevant to distance delivery of healthcare services, which has helped shape perspective and increase confidence in technology. Overall, interest in telemedicine has continued to accelerate with the decentralization and expansion of medical system via regional care centers and sister institutions, serving as a catalyst and focal point for such demand. For example, in breast cancer care, telemedicine has improved the velocity of a critical care pathway via the use of teleradiology, telepathology, and teleoncology consultation. And this strategy has made possible the establishment of same-day breast biopsy clinic, accomplishing one day what formerly took for up to 7 days. Ontario Telemedicine Network, OTN, was established in 1997 with the vision that telemedicine will be a mainstream channel for healthcare delivery and education, and using this streamlined process to bring patients the care they need where and when they need it. An independent, non-for-profit organization was funded by the government. The top 5 therapeutic areas were mental health, internal medicine, primary care, oncology, surgery, store forward asynchronous consults were supported in dermatology and ophthalmology, either as urgent or emergent virtual acute care. Also, OTN supported telestroke, acute burn, crisis psychiatry, trauma, critical care, long-term, and learning and meeting. And this OTN support 19,000 education events at 1 year, reaching up to 400,000 learners using multi-points video conference, web conference, webcasting technology, and a chronic disease management. So going forward, OTN will include the supporting signal harmonized collaboration model. There focus on the improving adoption by providers, organization, and clinical programs, and simplifying the process of organizing and doing telemedicine. In support of this goal, OTN offers online tools to find consultant-appropriate patient sites and book telemedicine events. Video can now be done from PC and laptops, as well as traditional video conferencing system. The home care program uses remote monitoring devices and support software, bring care closer to home. So what is the business model? Any organization or provider connected to the healthcare system must first become a member in order to access OTN services. OTN primarily funded by Ontario government, that's why it was supported. In Canada, Health Infoway has also provided funding for several significant development projects over the past 6 years. The diffusion of telemedicine accelerating and en route to reaching the next level, which is becoming an everyday part of the healthcare system in Ontario. Both the catalyst for the telemedicine and service provider OTN is leading a change to continue to simplify its use for institution providers and patients. The 10 state medical boards issue a special telemedicine license, including Texas, and each of these boards have distinctive requirements and features. For credentialing and privileging, the Joint Commission default rule is used, and that in the organizing sites is responsible for the credentialing process. More current regulation and statutory law regarding payment, reimbursement, billing practices, and privacy is at a federal level. So what are the barriers and solutions to implement the telemedicine and telesurgery? The other essential caveat of institutions' missions are education and caring for underserved patients, and thus most broadly, the goal of teletechnology, teleoncology would be connect physicians internally and externally and with patients wherever they are located. It was pointed out that the regional care centers' telepresence is currently used to interact with community healthcare providers for cancer prevention programs such as tobacco use cessation. The panel cited a strategy that would achieve these goals, namely a phased process that would initially rely primarily on grant funding to establish which pilot program could be scaled up and implemented for clinical practice. Overall, the group agreed that any effective strategy for teletechnology practice must produce the same outcome as current institutional practice model, regardless of the location. The other clinical practice, where the Robert Williams focused on specific question of how to best connect physicians at MD Anderson main campus with those at affiliated sites, such as sister institutions. It was noted that multidisciplinary care of colorectal cancer was currently widely distributed and available at all sites, including the main campus and affiliation. The coordination would ensure that patients are triaged to the appropriate care center that offers the best treatment for each patient, including clinical trials and other options. The group noted that financial remuneration is currently a distinctive for peripheral sites. The consensus was that there will be a need for an agreement between them regarding the telemedicine service, and that would foster relationship between providers and patients. Buy-in from physicians is essential. In pursuit of this strategy, one must determine from physician what aspect of cancer care within their discipline and current patient population would be most suitable for technology. The group recommended that the best way to approach this problem would be move forward in introducing tele-oncology, a standard operating procedure within each separate clinical department. So what is currently available? It consists of surgeon workstation with high resolution color 3-dimensional image with adjustable magnification. There was also a stereo audio input and force feedback grasping, where there be motors in the surgeon console instrument. That it's almost similar like robotic surgery. And this is show how does it happen. It is almost mimicking the robotic surgery, where the surgery is done in a different location from the console. By 2000, 131 patients had been operated using Da Vinci TM system, now used into REST-TM technology. Larger operating reports are necessary to accommodate these complex articulated instruments. Using such a voice-controlled automated endoscopic system for optimal positioning, robotic arm to hold the camera. So what are the benefits of telesurgery? It may enhance and extend the skills and range of the surgeons through its use of robotic interface. Laparoscopic surgery has generally involved the surgeon viewing the surgical site and the absence of shadows, movements parallel to the device. It attached the operating table and is controlled by voice command or with a foot switch. A tremor will be eliminated, and this is a sort of technology allows surgeon to perform tasks that would be otherwise impossible. Robotic devices can also be programmed to be internally safe, with movement restricted to an area where it can be done no damage, and it is estimated up to 54% of surgical errors might be prevented. So what are the concerns? It may involve a number of specialist hospitals, states, or countries. And if a complication arises, it may be difficult to establish whether this was the telesurgeon mistake or the technical failing of the system. Conversely, it might be considered negligent to withhold access to telesurgery if it is available. Clearly, these medico-legal issues must be addressed. Licensing and regulations are another area in which there are few guidelines for the surgeon. One possibility is to develop standardized set of procedures that must be performed. And the major concern about telesurgery related to safety, a problem such as loss of communication between the surgeon and the operating theater. And nowadays, most of the robotic surgery are done in the same operating room, so I don't think there is a major concern at that level. So what about teleconferencing? It is teleconsulting, which is different from mentoring, and that they usually involve more demonstration, discussion than interaction and intervention. And it has been reported that 1 hour broadcast cholecystectomy over the internet undertaken as a facility study. Another 3 broadcasts of live cholecystectomy on the internet were set up by Gantzas et al. Internet security was assured by emailing participants with the identification code of the broadcasting computer. The delay time from the transmission was less than 1 second, with a data loss ratio of 0.1%. More private teleconference was performed between the Netherlands and Hawaii. The session was interactive, enabling questions to be addressed to the operating surgeon. And this is the telepresence surgery, where the surgeon is considered to be around and seeing the surgery himself with robotic surgery in a different location. The delay was 155 milliseconds, safely below 300 millisecond safety limit, and the operation was completed in 54 minutes with no intraoperative complication. So what are the potential applications of telesurgery? The following surgical procedures have been performed using telesurgery, and therefore the systems were tried over short distance without communication links over a wide area. To extend the procedure for surgery at a remote site would require one of the wide area communications. And monosystem laparoscopic cholecystectomy was performed in 1997, and that was require up to 135 minutes, depending on the level of the inflammation of the gallbladder. And that study was done in 2001 over 48 patients. The three-dimensional camera instrument for clip placement, liver retraction, grasping, and electrocautery were controlled from the console. In three procedures, minor technical adjustments were made to the equipment, and the operation was converted to a conventional procedure in one patient owing unsatisfactory instruments. I think that was our last slide. Any question؟ أي سؤال يا أخوان؟ أي سؤال من الزملاء؟
So how many centers are actually doing this telesurgery in Saudi Arabia?
Well, actually, we have robotic surgery, but to be honest, we don't have telesurgery as expected. And doing surgery in remote areas is not yet started in Saudi Arabia. I think for legal issues.
Do you have a department of telemedicine or telemedicine basically in the Ministry of Health in Kingdom of Saudi Arabia?
Yes, there is. There is the e-health, and is considered one major part of the transformation. But I was invited last year with the deputy minister level for discussing the requirements for telesurgery. And I told them my requirements, and they are working on it. Because in the whole country, they are working on telemedicine, actually, or teleclinic, or telecounseling. But not yet telesurgery is considered. Simply, it's either you go for robotic, which is too far, too expensive, or you go for telesurgery. But telesurgery, again, it doesn't have an exact standard in the whole world. Last year, I presented, as I told you, in Rome, one paper about non-robotic telesurgery. It is not a must to have robotic surgery to do telesurgery. And my opinion was accepted in that scientific meeting in Rome. And the European robotic surgery last year, European robotic surgery in Rome, I think it was in November 2022. So hopefully we can work together with the international society, like professors from your side, to establish something like telesurgery principles in the Middle East.
And in your undergraduate curriculum, have you started introducing this to your potential medical colleagues, young doctors?
No, for the undergraduates is not yet, because this is too far for them. Even robotic surgery is not included in the curriculum for the undergraduates. I think this is all over the country. I believe so. But in the postgraduate or the training programs, it depends on the training institute. If the training institute have robotic surgery, they would at least give some elaboration. Although in our training center in Saudi Arabia, they consider the robotic is too far from the training for the postgraduate because it requires a very advanced technique and special training. So I don't think it is a part of the training. What about you in Malaysia? Do you consider this for the undergraduate?
Okay, so I can't say for the undergraduate program in the public university, but in Sunway, I think they already have a curriculum for telemedicine, especially in the ethical and the legal aspect of it. So I think in Sunway Medical University, there's actually a curriculum for that. And I think it should be introduced very early on. I think there should be, yeah, I think the young doctors need to know it from undergraduate so that they have a clear pathway, because we have too many don't call them doctors, we call them medical graduates, because they have not secured a place in the house for the housemanship, the internship. So they do have MBBS, but they're just floating around, just waiting for placement to be trained as housemen before they can be given the full license to practice. So this pool of medical graduates, they are clueless where to go. So the Ministry of Health have created a non-clinical pathway, a research pathway, and they're not doing much about medical telemedicine. We have a department in the Ministry of Health, like I mentioned yesterday. They are supposed to review the Telemedicine Act. Those who don't know, in Malaysia was Malaysia was the only country with the Telemedicine Act in 1997, and that was mainly it's politically driven to control our people from sharing fake news, but it covered as well. Mahathir had the foresight to create this multimedia super corridor. So we had that Telemedicine Act, and it's still not being changed. However, it's outdated. So the last that I asked the telemedicine unit 2 years ago, said, oh, we have a sandbox, but nothing has been done, honestly, because we can't charge patients yet. So the timing of, the political instability, we want to charge patients. Our society is not an insurance aware and affordable society to subscribe to insurance. So it's just not thing.
Yeah, I agree. I have a few comments here that Dr. Wala is saying there are specialists in the Arab countries. Yes, I know. I agree with you. Yes, we have specialists, but the issue is not the specialist. The issue is the whole idea and the whole thing. Does it worth going through or not? Another question from Dr. Rida, but in Arabic, he's saying, what is the average manpower from the surgeon and the assistant, and how long it will take? I think Dr. Rida is already a surgeon. He knows these details. I agree with you. As anything in life, there are some people who support and some people who are against. I am the same thing. I am with and against. I am with because this is a new technology and requires some attention, but I'm against higher and higher cost. The robotic will continue to be higher cost. It will require the docking before surgery, require a long time at the robotic, and the cost of the disposable are high compared to the conventional laparoscopy. I understand in some specialties like urologists, if they are doing prostate surgery, it's a very tiny place. Robotic is the best, but the expansion of robotics over the last decade is massive. And they are speaking now about doing mastectomy by robotics, doing cholecystectomy by robotics, it's too much. It's too much. And the cost is not justified. I know in some countries, without labeling them, the insurance is covering those technology. But again, we have to be very careful because there are some investment on those companies. Like United States, they already the manufacturers, so they have to support their companies, and they have to distribute more from their products all over the world. But again, it's this is it's you know, an open market. If you think this is good for you, go ahead. But if you think this is costing you too much without justification, you have to think again. And again, what are the advantages between robotic compared to laparoscopy? And what are the advantages? Again, 20 years ago, we were discussing what are the advantages of laparoscopy over open. But nowadays, you are asking what are the advantages of robotic over laparoscopy. So I think we are shifted over the last 2 decades. That's why there are some academics or physicians or surgeons, they are considering telesurgery as a separate entity from robotic surgery. That's why I'm saying that we have to discuss non-robotic telesurgery in the future. Another question, I think there are no more questions. I think that's it. So we will have a break for 20 minutes for Asr break. I think in Saudi Arabia, we have time zone almost.
To have a seamless presentation without any interruption, I'll be muting off my video because my internet is relatively slow here. So I hope the organizer won't mind on that. Okay. So as he's being introduced to me, I'm Professor Dr. Nishat Ahmed Sheikh from All India Institute of Medical Sciences, Deoghar, and representing India on the Indian perspective on medical, legal, and ethical challenges in telemedicine. Yeah. So just to have a brief understanding about the telemedicine, and it just mean healing from a distance. And according to the World Health Organization, the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment and prevention of disease, injuries, research and evaluation, and for the continuing education of healthcare provider, all in the interest of advancing the health of individuals and their communities. Before we proceed further, let us have a brief background of healthcare system in India. India's population as of now do not enjoy the equal and universal provision of healthcare services. You'll be surprised to know barely 9% of the population is covered by the health scheme, and the government spent a meager of 0.9% of its gross domestic product on health. On the contrary, the recommendation of WHO is of 5% minimum. Anyway, we have a categorization of urban and rural specialists in India, and around 80% of the specialist doctors do work in urban areas that account for only 20% of the population. Indeed, only 2% of the specialists operate in the rural areas of India. And if I talk about the healthcare infrastructure, we have around 2.2 beds available per 1,000 people in the urban areas, and a very pathetic situation that is a meager of 0.19 beds per 1,000 in rural areas. So this is something of physical infrastructure challenges. If India were to create a physical infrastructure to cover all the people in the rural areas at the current population level, my government would have to set up minimum of 700 hospitals with a capacity of 250 beds, which in turn would require a huge investment in the health sector to build up the infrastructure without being sure of availability of skilled manpower. Reaching healthcare to all. Telemedicine offered the best possibility of reaching healthcare to all. This was the ambitious my government ambitious project, which was due by 2015. But anyhow, the aim is to bring healthcare to even the most remote villages by harnessing satellites, information technology, and existing health facilities. Primary healthcare facilities for the rural population are grossly inadequate, despite several initiatives by the government and private sector. A significant proportion of patients in remote locations could be successfully managed locally with advice and guidance from specialists, super specialists in cities. Telemedicine thus has emerged as a key driver of public-private partnership for healthcare delivery to the remotest village in India by harnessing satellites, information technology, and existing health facilities. So coming on to my presentation on the legal status of medicine in India. The Telemedicine Act in India was passed way back in 2003 on the 9th April, and it clearly defines the telemedicine, the practice of medicine delivered across distances via telecommunication, including audio, visual, and data communication and interactive video technology performed by licensed or otherwise legally authorized individuals. Medico-legal issues in doctor-patient relationship. Patient trust healthcare professionals while seeking treatment and confide in them. The lack of face-to-face contact in some modes of telemedicine is seen as a barrier to adequate development of doctor-patient relationship. It is essential to maintain trust of the patient to meet legal requirements. Healthcare providers are obliged to establish good doctor-patient relationship. Informed consent in telemedicine. It is an important medico-legal requirement while treating a patient. Failure to do so is a tort and crime in India. Consent should be obtained for any medical interaction, whether it is in person or at a distance, such as telemedicine and virtual consultation. Consent should be obtained for telemedicine interaction, transmission of data, treatment, monitoring, and consultation. Further, it is important to clarify whether the medico-legal value of informed consent in telemedicine is the same or different with respect to traditional face-to-face interaction. There is enough evidence that in many specialties, virtual consultations such as video conferencing is clinically as good as in-person consultation. Hence, informed consent can be taken traditionally and properly documented. This is also highlighted by the World Medical Association statement of the guiding principle for the use of telemedicine for the provision of healthcare. Evidence supporting telemedicine. Informed consent in telemedicine is mandatory in countries like Malaysia, France, UK, South Africa, and in California, United States of America. Malpractice and liability in telemedicine. Can physician be sued for medical practice, malpractice in telemedicine and virtual consultation? And can they be protected by medical indemnity insurance? Few important points to remember in this is duty of care. Once the doctor-patient relationship is established, it is the responsibility of the doctor to provide due care and treatment, which is expected from the professionals in the given circumstances. Role and responsibilities. The duty of care must be established in all telemedicine encounters to clarify responsibility for the patient, caregiver, as well as other involved healthcare providers. Healthcare professionals should clearly define their roles and responsibilities regarding the various aspects and extent of treatment. Privacy in telemedicine. The right to privacy has been an integral part of medical ethics since the time of Hippocrates and is supported by various codes, including the International Codes of Medical Ethics. It mandates that the health practitioner must maintain confidentiality regarding personal information of the patient even after his or her death. Every individual has the right to privacy, even in telemedicine. There is the potential for leakage of electronic records of a patient. The onus for the safeguarding this information has to be on the medical practitioner. Securing the transmission of information. Information must be transmitted in a secure way. Password security should be maintained to avoid unauthorized access to the information. However, privacy cannot be granted with the use of telemedicine. Product liability in telemedicine. It is the liability of the manufacturer for any harm caused to the patient by a defective product. Thus, it means the duty of care is owned by the manufacturer, which includes the manufacturer of the computer system compatible for telemedicine, manufacturer of compatible software, manufacturer or supplier of various accessories related to telemedicine network provider. Health service provider who is using the technology and service company responsible for the maintenance of the whole telemedicine unit. Now coming on to the rights of the patient in telemedicine. In traditional medical practice, certain rights of the patient have been recognized, such as the right to get treatment, choose a doctor freely, change doctor at any stage of treatment, right of compensation, right of confidentiality, right of dignity, right of grievance redressal, right of information, and right to refuse treatment. The same applies to the practice of telemedicine and virtual consultation. The patient has a right to receive one's medical record in the electronic format, to know standards and safety guidelines. She has the right to be informed regarding authorization or registration status of the service provider and to know the various complaint process which he or she can use in case if he or she suffers any harm during the consultation. Certain reimbursement challenges in telemedicine. Currently in India, we do not have any provision for the reimbursement for the medical insurance in telemedicine practice. Whether telemedicine was required or not in the given situation is another condition which should be cleared for reimbursement. Liability in civil negligence. Civil suits could arise out of breach of contractual obligations between the telemedicine service provider and the patient user. The integral components to prove negligence are established by duty and dereliction of duty, which are directly related to the damage caused. So certain sections of Indian Penal Code, the liability in criminal negligence, this criminal prosecution takes place before the criminal courts for grounds such as the commission of offences under any criminal statute, most notably the Indian Penal Code, way back 1860, where the negligence is gross in nature and proven beyond reasonable doubt. The common charges faced by the doctors and other providers of such services are causing death by negligence, which shall be booked under Section 304A of IPC, endangering life or personal safety of other under Section 336 of IPC, causing hurt by an act endangering life or personal safety of others, Section 337 of IPC, and causing grievous hurt by an act endangering the life or personal safety of others under Section 338 of IPC. Punishment includes imprisonment as well as fine under the relevant sections of IPC. Vicarious liability in telemedicine. In the provision of e-health services such as telemedicine, where there is employer-employee relationship, the employer could be proceeded against due to the principle of vicarious liability, if deemed liable for act and omission of the employee arising in course of his or her employment. Liability under the Consumer Protection Act 1986, which was repealed in 2020 again. In India, the Consumer Protection Act allows the consumers to claim compensation from service providers in case there is deficiency in the service provided. Consumer can file claims for defective products and unfair trade practice. Consumer forums have been set up at the district, state, and national level to hear such matters. We do have a disciplinary control by the National Medical Commission. A patient is entitled to raise a complaint with the relevant state medical council against a doctor for professional misconduct. If complaint against the doctor has not been decided by the state medical council within 6 months from the date of receipt of the complaint, the medical council, that is National Medical Council, on its own or on the request of the patient, can ask the State Medical Council to decide on the complaint or to refer the same to the Ethical Committee of the National Medical Commission. There are certain challenges and the future of telemedicine. There is much hope for the future of telemedicine in India. With the rapid advancement in technology, telemedicine will become easier and more widely accepted in coming years. For successful integration of telemedicine with the existing health structure, we need to develop policies and guidelines. The future direction and challenges could be institution of regulatory authority in telemedicine, standardized format of information to patient and consent form with the opinion to opt in and out of telemedicine, mandatory telemedicine courses for all medical students, specifically postgraduate students, and refresher courses for medical practitioner and technical staff. Responsibility for privacy, confidentiality, and security of patient information and treatment. We need to frame certain guidelines and standards. There should be a clear guidelines for teleconsulting insurance, clear guidelines on issue of telemedicine across national borders, standardization of equipment and teleservices with periodic check and submission to a regulatory authority, equipment liability, maintenance, and safety, telemedicine laws for information storage and access. Dedicated staff to manage telemedicine services will be required. Coming on to the medical legal issues and connectivity, there is an urgent need to clarify medical legal issues pertaining to the use of telemedicine through legislation so that the doctors can use this service without reservations. There is also a need for an open platform for connectivity to use telemedicine, which means that the telemedicine facility should be available easily in a secure manner to maintain confidentiality and privacy in doctor-patient relationship. The use of smartphone-based application should be developed to avail healthcare services so that the patient can contact doctor without the need to go for consultation physically. There are certain costs of telemedicine. In most situations, telemedicine is beneficial. It gives access to the healthcare services in remote areas and to those with mobility issues such as elderly. Therefore, it has the power to overcome geographical barriers to provide healthcare services. It may provide an opportunity to reduce healthcare spending and save time for the patient and caregiver. With the advent of telemedicine, a medical practitioner or hospital can consult with different specialists irrespective of their location. Telemedicine helps the patient to engage with their healthcare providers more frequently in a convenient way, which may result in better doctor-patient relationship. The follow-up of patient is likely to be better, which may improve outcomes. Overall, to conclude, the telemedicine has the potential to provide better healthcare services to the masses. But equally, there are certain cons of telemedicine. Telemedicine has some downsides because of its virtual nature. It requires infrastructure and technical training. It may reduce direct interaction of patient with doctors because online interactions are impersonal, and to make complete diagnosis, physical examination needs to be done. There is lack of standardized format to the interaction and the absence of consent form for either opting for or refusing the services. Telemedicine is still not included in the medical curriculum in India. Beside ambiguity regarding responsibility in case of negligence, there are certain concerns about privacy, confidentiality, security of patient information, and treatment. There is no clarity with respect to medical legal issues arising out of telemedicine. Currently, in India, no health insurance policy factors in telemedicines. That's all from my side on the medical legal and ethical challenges in Indian perspective. Yeah, any questions?
Yes, thank you very much, Dr. Nashat. It's really important to know the pros and cons for telemedicine in different parts of the world.